female, active duty Army officer. Prior Division I volleyball player. She was a right outside hitter. Off without any other explanation of this patient, what does that tell you about this patient?
She uses her right side more.
What's that?
She uses her right
Well,
side more.
let's just talk about, generally speaking, like, what do you guys have some picture of what this individual looks like?
Athletic, strong.
Yeah, she's an athlete, right? And everything about her, she looks like an athlete. She looks like an athlete. She moves like an athlete. So, anyways, like you can go ahead and picture that this person is athletic. This person is kind of outside of the norm of the normal average person that comes into a physical therapy clinic, right? Can we at least agree on that, right? And we would agree that somebody who's an athlete probably has to rehab like an athlete and not like somebody who's 40 years old and sedentary and works at IT and doesn't ever work out and stuff like that, right? So prior D1 volleyball player, right outside hitter, she played for 4 years. She had a 6-month history of knee pain with running. The pain was centered on the anteromedial joint line, so right about there. She had no locking, so her knee never kind of stopped moving, and she never had to like physically manipulate it to get it to move. Again, there was no catching, no clicking. The pain increased with increased mileage, and then she had some minor pain with just stationary positioning. Whenever she'd be sitting at her desk for long periods of time, she would have some mild pain, but it was really, really tied to how much she was running. She had no pain with resistance training, and in fact, whenever she did resistance training, it actually made her symptoms better. So she presented to the physical therapy clinic, the physical exam notable for a likely meniscal pathology because physical therapists are pretty good at diagnosing injuries. And she had pinpoint pain on the anteromedial joint line, and if you look at the diagnostic accuracy of tests for meniscus pain, tenderness on the joint line is the best thing that we have. It's better than any of the stress tests that we do. Everything seemed like it was a meniscus tear, but there was no locking symptoms, and didn't feel like she needed any escalation of care because she was doing just fine with that. Put her on a linear progression barbell training program, reduced her training mileage, increased the amount of time because she still had to do some conditioning. So did some sprints, hill sprints, high intensity intervals, and she still did some agility training. Because she was an athlete, she still wanted to train like an athlete, right? So there was no advanced imaging taken during that first course of physical therapy. I understand the literature, and if you look at the literature on meniscus surgery, they take people with a meniscus tear with no mechanical locking symptoms. Conservative management is better than a sham surgery where they actually go into the knee joint but don't do anything. And that's even better than actually doing a meniscus debridement. So they can fake you out. They can do a head fake surgery, and you're actually going to get better than if they did their regular surgery. So whenever I was in physical therapy school, like I was a part of my research study was a randomized controlled trial where we were doing dry needling for patellofemoral pain syndrome, so just runner's knee pain. And the control arm was a sham dry needling procedure. So what we used a blunted object to simulate dry needling, but it actually didn't puncture the skin. And guess what we saw? It was exactly the same as if you actually stuck the needle in the skin. Because we talked about placebo effect, right? You think you're getting a surgery, you think the surgery is going to work, and there's a belief that you're going to get better for that. All right. So anyways, the diagnosis provided to this individual was left knee pain. Maybe it's because I'm just not that smart, but to me it just seemed fine to just say left knee pain. I've got 3 diagnoses: low back pain, knee pain, shoulder pain. It's about all the diagnoses. My IQ's not that high, so there's only so much I can do. All right, so 6 months into the rehabilitation program. So remember, this individual's an active duty Army officer, so there's a lot of competing requirements, stuff like that. But at 5'10", probably 130 pounds, 140 pounds or so, got her squat up from 70 pounds initially to 185 pounds, deadlift from 85 to 265. Pain was 0 out of 10. No symptoms with running up to 3 miles. Whenever she did run a little bit farther than 3 miles, she started to have some dull, aching pain, but for the most part, she's doing pretty well. All right, so she was sent back to physical therapy, and guess what? Lo and behold, the prescription 3 times a week for 12 weeks. She was instructed to stop all resistance training exercises because the patient ran the risk of, quote, destroying her knee.
God, see why everybody hates you people?
Rip, you know this more than anybody. Nobody hates me more than I hate me. All right, so
That's a whole nother seminar, though.
she's gonna, yeah. That's really funny, man. It's gonna be hard to come back from that. All right, so she risked destroying her knee. Why did she risk destroying her knee? Because the physical therapist that did the initial evaluation on her at that second encounter assessed the same exact thing that I did, that she had a meniscal tear. Doesn't understand the research, maybe a little bit dogmatic, and says you're going to destroy your knee. So what we need to do is we actually need to rehab you. We need to rehab you appropriately. This is the actual prescription, ladies and gentlemen.
Step down. What's the Spanish squat? You're like, hola.
Yeah.
Sí.
Who knows?
What do you say?
Okay, all right. So, all right, I got to get control of the room again. Does any of this surprise anybody in this, that this is what was considered a rehab program? This is for a Division I athlete, a 4-year Division I athlete, as an outside hitter, which is one of the more powerful positions to be on a volleyball court. Person played Division I. This person is in the top 1% of athletic individuals, was squatting 185 pounds for 3 sets of 5. But we need to make sure we stretch the IT band, which is absolute bullshit. If you've ever seen the IT band in cadaver lab, you're not stretching it. You're not stretching it at all. So we got to make sure that she steps down on a small step, but we're going to progress.
Cliff is like, that's advanced.
So how is this guy able to ignore the part of her medical history that he didn't agree with? Because that's exactly what he did.
Because there's something that happens in medicine where if you're licensed, you're credentialed, you have some autonomy to practice medicine or practice your facet of medicine as you see fit. And his interpretation of it was that she needs rehab. She doesn't need training, she needs rehab. And so we go to kind of a dogmatic physical therapy approach, that this individual probably had somewhere between a 22 and a 24-inch vertical. This girl could straight jump out of the gym, but she's got to start stepping down to make sure she can control her knee on the way down. Sidestepping, Spanish squats, so cultural appropriation squats.
What are Spanish squats?
I'll talk about it in just a second. All right. So LAQ 3 pounds with an ankle weight.
What's it like?
Long arc quad, which is basically
Jesus Christ.
this, with 3 pounds.
Okay.
With 3 pounds. She's squatting 185, she's deadlifting in the mid 2s, but she needs this 3 pound weight and do long arc quads. And of course, it's not physical therapy without a Bosu ball. And then that brings us to Spanish squats. All right. Because front squats would just be too fucking complicated. What it is you take, like, say something like a TRX strap, and you put it around somebody's proximal calf, and they step back as far as they can to get an anterior glide on the tibia, and then they do squats like this,
Sissy squats or whatever.
pulling the shit out of the tibia anteriorly.
PCL. Why would you?
I don't know. I have no idea why you would do that. I have no idea why this would fit into the rehab of a meniscus tear, why we should just maximize shear and then load it in shear. I have no idea. I don't know, but this is what physical therapy does. Because the idea is that it more preferentially activates the quadriceps muscle, and obviously she's got some quad weakness because she only jumps higher than most anybody in this room. Yeah, they're like 130 pounds body weight. Obviously, she's not quad dominant. She's got quad lack of dominance. We need to do that. But like the front squats would just be so much easier, I would think. But apparently not. All right. So then this brings us back to kinesiophobia. All right, so kinesiophobia is the primary problem caused by or exacerbated by the traditional rehab approach. And it's exactly for the same reasons that we've talked about, where rehab falls short. Don't do that, you're going to destroy your knee. For a less motivated individual, what is that going to do to that person? If this run-of-the-mill person has been going through a resistance training program, seeing good results, and then they go to a doctorate educated medical provider and the person says, you're going to destroy your knees doing that. Guess what that person's never going to do again? The person's never going to do that. But then that's fear avoidant behavior. But do you see where now that person becomes scared of doing that motion? Kinesiophobia is bad. It's very bad. There's strong evidence for an association between greater kinesiophobia and greater levels of pain and disability. This is coming out of the Suarez article 2018, which I think is one of the best articles I was able to find about kinesiophobia and actually kind of calculating or coming up with the impact of kinesiophobia. Moderate evidence for greater kinesiophobia and higher levels of pain severity and lower quality of life. So whenever people are scared of movement, there's moderate evidence to say that it lowers their quality of life. We're not just talking about how much they can lift in the gym. We're not talking about their training frequency. We're actually talking about quality of life measures, which are asking things about like participation in life, normal activities, playing ball with their kids, taking walks, being able to go places, lower quality of life with kinesiophobia. Moderate evidence that greater kinesiophobia is predictive of progression of disability over time. If we instill kinesiophobia on somebody, there is a much greater chance that they're going to have higher levels of disability. They're going to withdraw from activity. They're going to withdraw from industry, from gainful employment because of this. And we do this all the time. People don't talk about this because it's lesser known, and the 3 red asterisks means because I'm the only one who talks about this because this is my own idea, right? It's training barrier construction. And lesser known because I'm the only one who knows about it. Now you guys know about it. All right, so this is how I define training barrier construction. It's a specific type of external party nocebo effect. So this comes from somebody else. It doesn't have to be a clinician, but it comes from somebody else that is characterized by a strong or rigid recommendation of an artificial training restriction that is most commonly dogmatic and not supported by evidence, biomechanical analysis, or through the recommender's experience or expertise. So what I'm saying here is this is the thing that you hear people say, don't squat below parallel because it's bad for your knees. It meets all these classifications. It's an external party that's telling you that. It's strong and rigid. It's absolutist. Don't squat below parallel. It's bad for your knees. Absolutist language. They're not saying, well, you could squat below parallel if. They don't have an if. You just don't do it. It's an artificial training restriction. There's no reason why somebody should do that or have to do that. And they're not supporting it with either evidence or a biomechanical analysis to say, don't squat below parallel because when you do this, this happens. Clinician-induced nocebo likely second only to diagnostic terminology without patient education. So whenever a clinician does this, this is likely the second worst thing that clinicians do on a regular basis whenever it comes to inducing a harm with a patient. And this is just my own interpretation of after a couple of years of clinical practice, that I think that we construct these training barriers for people, and that's the second worst thing we do. The worst thing that we do is that we use scary diagnostic language. And scary diagnostic language that makes somebody want to go home and Google that is likely a bigger issue. But second, really only to that, would be us inducing a training restriction on somebody. Don't squat because it will destroy your knees. Is there really any evidence to say that? No, it's artificial. It came from a clinician. It was an external source. It's dogmatic. It's absolutist. Probably need to tweak this definition, but this is how I see it. And we see that it's externally produced. Other individuals induce this on us, but it's internally sought. People want to know this information. They want you to put this training barrier on them, which is why people come into my office, and one of the most common questions I get asked is, Major Morris, Dr. Morris, whatever, what can I not do? I'd like to answer, I don't know. You tell me. You tell me. It's not for me to determine.